Dr. Park, to my far left, Dr. Myung Park. She is an associate professor of medicine in the Division of Cardiology in the School of Medicine. She's also director of the Pulmonary Vascular Disease Program, and at the same time, she serves as the director of inpatient cardiology at the University of Maryland Medical Center. Dr. Park has led numerous clinical trials in the treatment of pulmonary hypertension, as well as heart failure and heart transplantation. She's extensively published in the areas of management and treatment of pulmonary hypertension, cardiac transplant immunology, ventricular assist device, treatment of cardiac rejection, and medical therapies for patients with end-stage congestive heart failure. So that's a brief bio of Dr. Park. Dr. Davis sort of first set things up for you, and that is diabetes. Clearly, yes. One of the complications of long-standing diabetes is really cardiovascular complications. There are other complications related to, other causes related to diabetes complications as well. So let me ask you, when it comes to heart disease, recognizing risk factors, everyone would agree is key to optimizing outcomes. Yes. Key to optimizing, if we can identify those risk factors, either try to mitigate or at least eliminate them if possible. What would you say are some of these risk factors they should look for? And my follow-up question while I'm at it, and that is, many women either may or may not be aware of the fact that you think of breast cancer as the major cause of death, and not in fact realize that in women, cardiovascular disease can in fact, particularly young women, become the major cause of death. Would you comment on some of the things that you're doing in your team that could help identify those risk factors, at the same time try to mitigate or reduce the likelihood of complications that women, that everyone in general, but women in particular might succumb to if they were not well informed?
Thank you, Dr. Reese. I too like to sincerely thank being part of this distinguished panel. It is a privilege and an honor to be here and addressing these very critical issues. As I was sitting here, it occurred to me that we are operating in a society where we are battling the same enemy, trying to attack it from different angles. A lot of the same risk factors that you had mentioned and Dr. Davis mentioned are the same things that we mentioned that in essence really affect the system, the person as a whole. And stepping back, I mean, just looking at the numbers that affect the cardiovascular realm, we know that the latest statistics showing 80 million people having cardiovascular disease of some type, whether it be affecting the muscles or the valves or the coronary artery structure of some type. And we know that this definitely has bearing on the time and the aging, because majority of those 80 million people are those who are greater than 60 years of age. Not surprisingly, this translates into a heavy mortality. It is estimated that about 2,000 people die each day in the US due to cardiovascular disease, and that's about 1 in every 39 seconds. And again, translating that into an economic burden, it's about $300 billion that we spend direct or indirect costs that's related to heart disease, and it's about 15 to 20% of the total healthcare costs. So if you kind of put the whole spectrum of what we're dealing with, you know, in that kind of capacity, it is a staggering degree of disease that we're faced with. Now, we do have that, but the good news is we have made amazing strides in our ability to recognize and make interventions. Now, we have interventions on 2 different scopes, which we do at the University of Maryland. And to address your first comment, Dr. Reese, about risk factors, the risk factors that we deal with every day are the ones you've already heard about. Smoking, probably smoking is still the ones that we really can intervene, and those are the ones that really do have a huge impact on the development of, on the acceleration of, and ultimately the consequence of your heart. So I think these are the factors that we're learning. There was a recent land-breaking sort of a clinical trial or a study that was just published last year that for the first time really looked at these risk factors and said, you know, we have studied what the short-term effects of these risk factors are. What is a long-term lifespan effect of having high blood pressure, of having high cholesterol, of smoking and being a diabetic? And amazingly, and not surprisingly, very small percentage of US population were considered to be low risk, i.e. having no risk factors, about less than 5%. All the others, majority, had at least one. About 2/3 have two, if not more, of the risk factors. And for those individuals, you can see the survival curves were just vastly different, and showing again that despite all the interventions that we have, just addressing these very basic lifestyle changes is so important. And the other thing that study brought out is that these traditional risk factors really trump over the ethnic background or the age of the patient, in that you can definitely work at improving your chances of getting cardiovascular disease at any age, no matter what kind of background that you come from. So having said all that, I think one of the things that we try to address with our patient population is that at least by age of 40, everybody should have a sense and good knowledge of what your risk factor is. Knowledge is power, knowledge is key. Discuss with your doctor specific points, your blood pressure, your cholesterol, specific lipids. How about my body mass index? Is it appropriate? Is it, should I work on this? How much can I exercise? What should I do? And I think you really have to be your own advocate, your proponent, in asking these very diligent questions to your physicians. And the second thing that we do, and you mentioned about women, of course, American Heart Association has done a wonderful job in raising the awareness of heart disease in women. I think women are still surprised, and I see this all the time in our cardiac care unit, when they're told that they have a heart attack. My goodness, I thought, my uncle had it, my father had it, I never thought I would get it. And we do understand that due to hormonal changes that women go through, they are more vulnerable at a certain lifespan, such as when they are about going through perimenopause stage and postmenopause stage, where there is differences elicited in the lipid makeup due to during the menopause, for instance, once HDL, the good cholesterol, goes down, and the LDL, the bad cholesterol, tends to go up. High blood pressure also can set in at this time point, and also glucose handling changes, and then weight. Women postmenopausal has a greater tendency to gain weight. But not only that, what is also becoming obvious is that for women, these same risk factors that affect both men and women alike tend to affect women in a more diverse and more structurally adverse way than it does men. So for the same age group, for the same degree of, say, HDL, LDL, it affects women more adversely than it does men. So for women over the age of, say, 65, they really, really have to be diligent and very mindful of what the risk factor is and how they can improve that and to modify whatever factors that they can do. At the University of Maryland, one of the ways that we are doing and approaching patients at both spectrum of the cardiovascular disease is seeing the person as a whole. And I think one of the things that we do excel at is when patients present, no matter what degree or structure of the cardiovascular disease they may have, is really address the fact that, okay, what kind of symptoms do you have? What is troubling you the most? And try to hone down what the diagnosis is, but also be mindful of that, we live in a system of our body, and you cannot really concentrate on one disease or one organ. I have many patients that come to me and my colleagues where they've seen 3, 4, 5 other physicians who's been told, I know you're short of breath, but your heart is fine, so it's not that. They'll see a pulmonologist and they'll say, no, it's not the lung, it's not the heart, it's the heart. So it's this kind of shoveling back and forth, when the simple truth is, it's really not one or the other, it is the both. And you really have to look at the whole system in that approach. So we try to educate the patients to try to let them know what their risk is, what they need to start by, and where they should start, in what capacity, recognizing that you have to stay within the realm that they're able to operate in, and really let them know that there are many different ways of intervening, medically, device-wise, surgically, but you cannot undermine or underscore the importance of really good living and exercising every day.
Thank you, Dr. Park. So clearly, Dr. Park has been emphasizing very much the important role of lifestyle. In fact, everybody has, for that matter. Everybody has emphasized the important role of lifestyle. And in fact, Dr. Cullen has made it very clear that many of the cancers are basically self-induced, lifestyle-induced. And the converse is true, that to the extent that we can actually alter our lifestyle, we can actually improve our health and reduce the complications, either the chance of developing diabetes or the need for certain organ transplantation, or clearly the impact on cancer, and most recently the impact on heart disease. So clearly we have a significant role that we can play as individuals in our own disease progression or disease initiation, but most importantly in our health maintenance.